Good morning. This is Dr. Kratika Mishra from Index Institute of Dental Sciences, Associate Professor, Department of Orthodontics. Today, I'm going to start with the topic that is myofunctional appliances. It is the most important topic in orthodontics. So let's start with the contents first. I'm going to cover introduction, definition, the basics of functional appliances, the classification, poses, treatment principles, indications, actions of functional appliances, case selection, VTO, objectives, common appliances in use, when to treat with functional appliances, limitations, complications, and conclusion. By definition, it is a removable or fixed appliance which favorably changes the soft tissue environment. According to Mills, it is a removable or fixed appliance which changes the position of mandible so as to transmit forces which are generated by stretching of the muscles, fascia, or periosteum through acrylic and wirework to the dentition and underlying skeletal structures. Loose fitting or passive appliances which harness the natural forces or orofacial musculature that are transmitted to the teeth and alveolar bone through the medium of the appliance. Now, moving further to the history, in 1879, Norman Kingsley explained that it is forward positioning of mandible and orthodontics in wide jumping appliances, that is the vulcanite. The drawback is tendency to relapse and even with the bite guide. In 1883, Rocks first used this first to study the influence of natural forces and functional stimulation on form, foundation, and both general orthopedic, functional dental orthopedic principles. Then in 1902, Perry Robin, he was the first practitioner to use the functional jaw orthopedics to treat a malocclusion, that is monoblock, in children with glossoptosis syndrome. In 1909, Viggo Anderson modified bite jumping appliances inspired from Benno Lischer's theory. In 1938, Carl Hoppel saw the potential of Rock's hypothesis and explained how functional appliances work through the activity of orofacial muscles. Anderson Hoppel had association with the activator, and he explained about the biomechanical orthodontics, that is the functional jaw orthopedics. In 1936, he collaborated on textbook which is based on the functional orthopedics. The father of myofunctional therapy in 1906 was Albert P. Rogers, who was the first to implicate the facial muscles of the growth, development, and form of the stomatognathing system. In 1905 and 9, Emil Herbst has developed the Herbst appliance. This is the Herbst appliance you can see on the screen. In 1957, Frankel gave the functional regulator. In 1977, William Clarks explained about the twin block, and in 1989, the magnetic appliance was developed by Blechman et al. Now, moving further to the classification of fixed functional appliance, according to Tom Scriber, it was classified as removable into group 1, 2, and 3. Group 1 is teeth supported, that is Catalan's appliance or inclined planes. Group 2 is teeth and tissue supported, that is activator and bionator. And group 3 is vestibular or position appliance with the isolated support from tooth tissue, that is Frankel's appliance, lip bumper, and vestibular screen. With the advent of fixed functional appliance, it is classified into removable functional, example, activator, bionator, or Frankel's. Removable of fixed, available in both removable and fixed type, that is twin block and Herbst. Then semi-fixed appliance, that is some components of fixed, some detachable, example, bolts and bars appliance. And another one is fixed appliance, that is Herbst, Jasper jumper, churro jumper, safe springs, mandibular anterior repositioning appliances, etc. Now, with the concept of hybridization of Peter Wick, is classified into classical functional appliance, example, activator and Frankel's appliance, in hybrid appliance, that is propulsor, double oral screen, hybrid bionators, etc. Now, classification by profit, it is classified into teeth-borne passive, that is myotonic appliance, example, activator and bionator, teeth-borne active, that is myodynamic appliance, Wilmer's appliance, elastic open activator, stockfish appliance. Then we have tissue-borne appliance, that is passive. It includes oral screen, lip bumpers. Then we have tissue-borne active, that is Frankel's appliance. We have functional orthopedic magnetic appliances. Now, the treatment principles. Depending upon the force applied, there are two treatment principles can be differentiated, that is force application and force elimination. In the force application, the compressive stress and strain act on the structures involved, resulting in primary alteration in the form with secondary adaptation in the function. In force elimination, abnormal and restrictive environmental influences are eliminated, allowing optimal development. Function is rehabilitated and followed by secondary adaptation in the form. Now, indications. Uses of functional appliance alone. Cases with mild skeletal discrepancy, proclined upper incisors, and no dental crowding. Use of functional appliance in combination with fixed appliance that is commonly used to improve the anteroposterior relationship between the starting the fixed appliance treatment. It is also used in class 2 cases, reduce the amount of comprehensive fixed therapy required, reduce need for orthodontic surgery. The interceptive treatment, it is used in early intervention where indicated when one wishes to utilize the growth enhancing effect. Extremely effective in reducing the relative prominence of proclined upper incisors, which are particularly susceptible to dentoalveolar trauma. Now moving further to action of functional appliances. Skeletal, dentoalveolar, and soft tissue effects of functional appliances reviewed by Dare and Nixon in 1999. These appliances can bring about following changes, that is orthopedic change, dentoalveolar change, and muscular and soft tissue changes. Moving on, the orthopedic changes capable of accelerating the growth in condylar region can bring about remodeling of clinoid fossa, and it can be designed to have a restrictive influence on the growth of the jaws, and it can change the direction of growth in the jaws. What are the dentoalveolar changes? That is, it can bring about changes in the sagittal, transverse, and vertical dimension, inhibition of downward and forward eruption of maxillary teeth, retroclination of upper incisors, proclination of lower incisors, lower labial segment intrusion, and leveling of curve of P and tipping of occlusal plane. The muscular and soft tissue changes includes improve the tonicity of orofacial musculature, remove the lip trap, and improve lip competence, removal of adaptive tongue activity, lowering of the rest position of mandible, and removal of soft tissue pressures from the cheeks and lips. Now moving further to the case selection. Age. It is usually done in the growing patients. The optimal age for functional appliance therapy is between 10 years and pubertal growth phase. The social considerations are dental considerations. There should be devoid of one gross irregularities. Then skeletal considerations, moderate to severe class 2 malocclusion cases are ideal. Mild class 3 malocclusion with reverse OZ and average overbite. Now, what is VTO? That is the virtual treatment objective. An important diagnostic test undertaken before making a decision to use a functional appliance. It enables us to visualize how the patient's profile would be after functional appliance therapy. It is performed by asking the patient to bring the mandible forward. If there is an improvement in the profile, it shows the positive indication, and if profile worsens, then it is a negative indication. Other treatment modalities are considered. Photographs are taken with the forward mandibular posture. Now, what are the common appliances in use? Starting with the first appliance, that is the vestibular screen. It was introduced by Neville in 1912. It takes the form of a curved shield of acrylic placed in the labial vestibule. It works on the principle of both force application and elimination, and vestibular screen does not contact the teeth as compared to oral screen. The indications are to intercept mouth breathing, thumb sucking, tongue thrusting, lip biting, and cheek biting. Mild distal occlusions, to perform muscle exercises to help in correction of hypotonic lip muscles and cheek muscles, and mild anterior proclination. The modifications are Port's modification and double oral screen, as you can see in the image. This is the another modification, that is a cross modification, and to reduce the bulk of allow the expansion when required. This is the courtesy Journal of Orthodontic Cyber Journal. This shows the modification in the oral screen and extension of the buccal loops. Now, moving to the next appliance, that is the lip bumper appliance. This combined removal fixed appliance used in both maxilla and mandible to shield the lips away from the teeth. Maxillary appliance is called as Denholz appliance. What is the use is in lip sucking patients, hyperactive mentalis activity to augment, encourage, and distalization of first molars. The most important appliance is activator. The activator indications are in generally actively growing patients with favorable growth patterns, that is class 2 div 1 malocclusion, class 2 div 2, class 3, class 1 open bite, class 1 deep bite, as a preliminary treatment before major fixed appliance therapy to improve skeletal jaw relations. For post-treatment attention, children with lack of vertical development in lower facial height. What are the contraindications of activator? Correction of class 1 cases with crowded teeth and caused by disharmony between the tooth size and jaw size. In children with excessive lower facial height, in children with lower incisors are severely procumbent, in children with nasal stenosis caused by structural problems within the nose or which are untreated allergy in non-growing individuals. What are the advantages? Uses existing growth of jaws, minimal oral hygiene problems, interval between appointments is long, appointments are short, minimal adjustments are requirement, and hence they are more economical. The disadvantages are it requires very good patient cooperation, cannot produce a precise detailing and finishing in the occlusion, may produce moderate mandibular rotation, hence contraindicated in excess lower facial height cases. Now, what is the mode of action according to Anderson and Hoppel? Is it induces the musculoskeletal adaptation by introducing a new pattern of mandibular closure, that is stretching of elevator muscles of mastication, leading to contraction and myotactic reflex setup, which releases the kinetic energy that causes the prevention of growth of maxillary dentoalveolar process, movement of maxillary dentoalveolar process distally, and which results in reciprocal forward growth of the mandible. In addition, a condylar adaptation by backward and upward growth occurs. Now, moving further to trimming of activator. In the vertical plane, that is, we require intrusion, only limited intrusion is possible. So, relative intrusion is one of the objectives. Incisor intrusion brought about by loading of the incisal edge, or you can do it by labial bow placing at the incisal third. If you want to go for the molar intrusion, it is brought about by acrylic plate touching onto the cusps. Acrylic plate ground away from the fissures and grooves, and if larger occlusal surfaces are loaded, reflex opening occurs, frequently resulting in less depressing action by the appliance. This is the trimming of the activator. Intrusion of the incisors can be achieved by loading of the incisal edges of the teeth. The labial bow should be below the area of greatest convexity or on the incisal third. Molars, it can be performed by loading on the cusps. The pits and fossas are cleared to eliminate the possibility of the inclined plane. Extrusion, indicated in open bite problems. Incisor extrusion, labial bow is placed in gingival 1/3, loading the gingival third, or molar extrusion can be brought by enhancing the eruption by grinding the acrylic plate from the occlusal surface, acrylic contacting the gingival 1/3 of the lingual surface. In the sagittal plane, if you want the protrusion, then loading of the lingual surface with the acrylic contacts, screening away the lip strains with passive labial bow or lip pads. Auxiliaries used are protrusion springs, wooden pegs, and gattapaja may be added to the lingual acrylic. This is the retrusion of incisors. The acrylic is trimmed from the back of the incisors and active labial bow is incorporated. Transverse plane, during selective trimming, only in the upper and lower molars are extruded. After erupting, eruption of antagonist can be controlled. Thus, both sagittal and vertical relationship can be influenced. These are the modification, bow activator by Schwartz and Wunder's modification for class 3. This is the propulsor, the Heron's modification, and reduced activator carbonator by GPR Smoon. Now, type 1 is distal activator, and this is the prognathism activator. So, these are the Karawatsky modifications of activator. Further, there are type 3, a pan activator, and type 3B, pan activator. Now, the wear time this first week, 2 to 3 hours a day during daytime, and second week onwards, 3 hours during a day while sleeping. Moving further to the next appliance, that is the Frankel's functional regulator. There are two main treatment effects, serve as a template against which craniofacial muscle functions, framework of appliance provided, and artificial balancing of environment. It removes the muscle forces in the labial and buccal areas, thereby providing an environment which enables the skeletal growth. The types are class 1, FR1, which is used in class 1, class 2 div 1, FR1A, which is used in the minor or moderate crowding, 1B is used with 2 in class 2 div 1, whereas overjet does not exceed 5 mm. FR1C is used in class 2 div 1 with overjet exceeding 7 mm. FR2 is class 2 div 1 and 2. Then we have FR3 for you, which is used for class 3 cases, FR4 for open bite and bimaxillary protrusion, and FR5, which is incorporated headgear indicated in long face patients having high mandibular plane angle and vertical maxillary excess. Next appliance is Bionator. It was developed by Palters in 1950, which is modified activator and is less bulky and more elastic. The three types, standard type, class 2 driven, having narrow dental arches, class 3 appliance, and open bite appliance. This is a standard type, class 3 and open bite appliance. The most commonly used appliance is twin block appliance with the marvelous results. It is a removable orthodontic functional appliance that is used to help correct jaw alignment, particularly an underdeveloped lower jaw. It was developed by William Clark in 1977 and effectively combines inclined planes with the intermaxillary and extraoral traction. The removable twin block is a tissue-borne functional appliance that is worn full-time. It helps to advancement of mandible. It is a two-piece appliance composed of upper and lower bite block. Orthopedic traction can be used in cases of severe skeletal discrepancies. This include in the use of concord face bow at night time. Upper and lower bite blocks interlock at 70-degree angle. Fixed twin blocks is similar to removable twin block, but can be used in non-compliant patients. It is similar in design to Herbst appliance. However, the telescopic tubes of Herbst appliances are replaced with two bite blocks. The advantages are very good patient acceptance. Bite planes offer greater freedom of movement and later excursion, less interference with normal function, significant changes in patient's appearance within 2 to 3 months. Next appliance is Herbst appliance. That is a fixed functional appliance developed by Emil Herbst in 1900. Indications are correction of class 2 malocclusion to retrognathic mandible, can be used as anterior repositioning splint in patients having TMJ disorders. Specific indications are post-adolescent patients, that is treatment completed within 6 to 8 months, and it's possible to use a residual growth of these patients, mouth breathers, and uncooperative patients. There are two types, banded and bonded Herbst. First one is the banded Herbst and the other one is the bonded Herbst appliance. The advantages are continuous action, treatment duration is short, less patient cooperation is needed, and it can be used in patients who are at the end of their growth, can be used in patients with mouth breathing habit. The disadvantages are cause minor functional disturbance, increased risk of development of dual bite with TMJ dysfunction symptoms as a possible consequence. Repeated breakage and loosening of appliance occurs especially in lower premolar area. Plaque accumulation and enamel decalcification can occur and tendency for open bite. Jasper Jumper is a relatively new flexible fixed tooth-borne functional appliance produced by Jasper in 1980. Actions are similar to Herbst appliance but lack rigidity. Basically indicated in skeletal class 2 malocclusion with maxillary access and mandibular deficiency. This is a Jasper Jumper appliance. Advantages that produces continuous force, does not require patient compliances, allows greater degree of mandibular freedom than Herbst appliance, and oral hygiene is easier to manage. When to treat with functional appliance? The best time to start the functional appliance therapy is the late mixed transition. Advantages of pubertal foods. What should be taken? Girls and boys along with early maturity should be assessed individually. Now, what are the limitations and complications? The discomfort as both upper and lower teeth are joined together mainly depends on patient's compliance, can be used only in favorable horizontal growth pattern, is present in cases of class 2 correction. It has to be removed during mastication, particularly when strongest forces are applied, and it may interfere with speech. Treatment duration is often long. So let's conclude our presentation with the global demand of orthodontics without braces continues to grow. It's an option that many parents and patients would prefer. Myofunctional orthodontics offers a viable alternative to traditional orthodontic methods. A functional appliance is the appliance that produces all or part of its effect by altering the position of mandible and maxilla. These appliances utilize the muscle action of the patient to produce orthodontic and orthopedic forces to restore the facial balance. The question that must be addressed in diagnosis is, does the patient require orthodontic treatment or functional orthopedic treatment or combination of both, and to what degree? Whether the patient requires functional appliance alone or need of orthodontic surgery, or to what extent functional appliance reduces the need for the surgery. The study of orthodontia is an indissolubly connected with the art as related to human face. The mouth is the most potent factor in making the beauty and character of the face, and form of the beauty of the mouth largely depends on the occlusal relations of the teeth. Our duties as orthodontists force upon us greater responsibility, and there is nothing which the student of orthodontia should be more keenly interested than in art generally. And especially, it's in relation to the human face, for each of his efforts, whether he realizes it or not, makes for beauty or ugliness, for harmony or inharmony, for perfection or deformity of the face. Hence, it should be one of the life studies, according to E.H. Angle in 1907. So these are my references, and thank you for your patient hearing.